Hello, everyone. Thank you for joining us today. My name is Momoko Abe, and I'm with the Japan Center for International Exchange. On behalf of our co-organizers, the Economic Research Institute for ASEAN and East Asia, I'd like to welcome you to the webinar, Community-Based Integrated Care for Asia's Aging Population. The topic today will be based on a recent policy brief we released that examined the lessons from Japan's policy on aging and how it paved the way to community-based integrated care. Over the past few years, increasing attention has been paid to this concept as a model for the coordinated delivery of various services, whether healthcare, long-term care, or social services to foster healthy aging and improve the lives of older people and their families. We will welcome Ms. Tomoko Sakota, the author of the brief, to share her insights from an impartial point of view as a journalist who has conducted various coverage and interviews in this field. The panel will be joined by speakers from South Korea, Thailand, and Vietnam, sharing how community-based integrated care is put into practice in the context of their respective countries. They come at the issue from different perspectives, representing academia, a non-profit organization, and the public health sector. It is hoped that through today's meeting, we will better understand how this model of community-based integrated care could be adopted and strengthened in such a way to address the needs of individuals. Before starting the session, I'd like to make a couple of housekeeping rules. This webinar will proceed mainly in English with simultaneous interpretation to Japanese provided. You may select your preferred channel from the menu bar on the bottom of the screen. If you have any questions during the webinar, please post them in the Q&A box, also available in the bottom menu bar, and we will address them as much as possible at the discussion later. We have also received several questions and comments beforehand, but we welcome any feedback that you may have, so please share those using the Q&A function, and we will try to get to as many as possible so that we can make this session an interactive and informative one for everyone. So without further ado, I would like to pass the lead to Mr. Shintaro Nakamura, the moderator for today. Mr. Nakamura is Senior Advisor on Social Security at the Japan International Cooperation Agency, widely known as JICA. Since joining JICA in 2010, he has been working on various projects related to social protection, universal health coverage, and aging, including a project on long-term care services known as LTOP with the Thai government. In fact, he is joining us from Bangkok this morning, and it's indeed our pleasure to have him moderate today's session. Mr. Nakamura, the floor is yours.
Thank you, Ms. Abe, for your kind introduction. Hello, everyone. My name is Shintaro Nakamura, and I will be the moderator for this webinar. Before inviting Ms. Sakota, I would like to outline the concept of community-based integrated care and its place in the global trend of aging policies. Community-based integrated care is promoted in Japan as a way of supporting older adults in need of care. It aims to enable older adults to live with dignity until the end of their lives in a community that they are familiar with. Formal care services and informal supports are coordinated and provided in the community. Formal services include health services and long-term care services by professionals. Informal supports include social support, frailty prevention activities, and companionship by people in the community. Ensuring appropriate housing is also essential, whether they are older adults' own houses or assisted living. Japan is not unique in pursuing a community-based approach. In the global aging, community care has become a focus of discussions in many countries and international organizations. For instance, in 2017, WHO issued the guidelines on ICOP, integrated care for older people, which provided the community-level intervention to manage declines in the intrinsic capacity of older adults. Many European and Asian countries promote a community-based approach. But what happens in each country takes different shapes because each country has a different context in terms of demographic structure, household profiles, socioeconomic conditions, institutional arrangements, policy environment, and values in each society. Now, let me introduce Ms. Tomoko Sakota. She's a journalist and a former senior commentator for Japan Broadcasting Corporation, NHK. She extensively covers health and medicine, welfare, and population aging and its implications on people's lives and society. Ms. Sakota, the floor is yours.
Thank you, Nakamura-san, for introducing me. Good morning, everyone. And Japan's experience in dealing with its aging population is a history of try and error. During the period of high economic growth in Japan, the country moved toward medicalization and institutionalization. But when the economy slowed down and got stabilized, the limits of that approach became evident. Now, having gone through a period of declining birth rates, increased urbanization, and shift toward nuclear families, Japanese society as a whole has once again become aware of local community resources and networks, and is now trying to replace the previous social safety net with the concept of community-based integrated care. Slide, please. Next, please. This compares Japan's population pyramid of 1950 and 2020. The aging population ratio rose from 4.9% in 1950 to 29.1% as of 2021, which is the highest in the world. After World War II, the birth rate increased in many countries around the world, producing what is called the baby boomers. In Japan's case, it is called the Dankai no Sedai, or literally the clamp generation, which includes those born from 1947 to 49. During those years, 2.7 million people were born annually. This is around here in the population pyramid. This generation is now in their 70s and around here. The large scale of this population group has continued to have an impact on Japan's social systems in various ways. It is no exaggeration to say that this generation has always been on people's minds when planning the systems to deal with older people. There is another figure I'd like you to see. I put it on paper, location of death in Japan. In 1975, the number of people dying in medical institutions surpassed those dying at home for the first time. This is just the section here. One of the reasons for the increase in hospitalization for the elderly is that the number of geriatric hospitals has increased overwhelmingly due to the free medical expenses. The family began to consider admitting the elderly to the hospital because it did not cost anything. Geriatric hospitals were built one after another because demand was expected. However, as you may have noticed, there is nearly nothing one can do as a medical treatment. The rehabilitation required for the after effects of cerebral hemorrhage may be necessary for the first few months, but it does not require a long hospital stay, and the rest can be done at home while exercising in life. People with dementia have nothing to do when they are in the hospital. On the contrary, the condition gets worse in an unfamiliar environment. In Japan, as medical expenses for the elderly put pressure on overall medical expenses, it became necessary to separate long-term care from medical care. Long-term care insurance was introduced in 2000. The three pillars of home-based services, home helpers, day service centers, and short-term care facilities, are covered by long-term care insurance. However, the current situation is that long-term care insurance alone cannot provide care for the entire 24-hour life at home. After all, the level of family and community resources are available is important. That is where the idea of community-based integrated care comes into play. It is a system that supports the elderly in cooperation with long-term care insurance, medical insurance, various local powers, volunteers, etc. What I wanted to convey most in this paper was to help readers understand the importance of community-based integrated care and to imply that other countries do not have to make the detour of medicalization and institutionalization. The current community-based integrated care is a municipality-based system that unifies healthcare and long-term care and promotes mutual support among members of the community. While this offers a degree of freedom to local governments in terms of how to implement the system, the flip side of that is that it creates a great deal of regional variation in the status of these efforts. I wrote about Kunitachi City, located in the western part of Tokyo, on paper. In this city, with a population of just under 80,000, the initiative is centered on a clinic that was opened 30 years ago and provides whole medical care. The doctor of the clinic, whose name is Dr. Kunio Nitta, has emphasized the need to shift the focus from medical care that cures to medical care that cures and supports. Nothing that it is important to consider the lifestyle and motivation of older people rather than just their medical care in order to ensure that they can live with peace of mind in their communities. I'd like to explain this with photos. This photo shows Dr. Nitta on the right, visiting a 90-year-old woman with dementia. It was just before COVID-19 pandemic. She had a fever for several days and was worried about her son caring for her. Dr. Nitta collected her blood and examined it at the clinic, confirming that it was inflamed. He then visited her again and touched her body for medical examination, reading the patient's pain with her facial expression because she couldn't speak. He diagnosed her with inflammation of gallbladder. The patient was given antibiotics at home. This photo shows the nurse explaining to the patient's son. This family has lived in this place for a long time, and his father was taken care of by the same doctor. The doctor and the nurse also know the situation of this family. This is a day service center using a private house near the elderly woman's house. She spends time here while her son goes to work daytime. 2 months later, she recovered completely. So this is a photo of her visiting the day service. The man pushing the wheelchair is the director of this center. Using a private house, it has a very homely atmosphere. This is a photo of volunteers who live nearby, cooking the food for people at the daycare center. The chrysanthemum that was taken nearby was made into tempura and mashed with a hand mixer to make it easier to eat for the elderly who have difficulty swallowing. After cooking, the volunteers and elderly will sit down and eat the food together. This is a community center, the place for elderly to get together, offered by the city. It is on the first floor of a newly built elderly housing by private sector. The center offers a monthly lunch service for the elderly. Elderly people also cook by themselves. 2 women in the middle with dementia are washing and cutting vegetables and cooking with proper support and guidance by the staff of the center. And here are the women who came to have lunch. Both are over 90 years old. The woman on the left uses this space to teach sewing. Just at the time of COVID, she taught people living in the same house to make a mask case with clothes left over material of kimono. This is mask case. Elderly people can live a lively life if there is an appropriate place and opportunity. Using these various resources in the community, community-based integrated care aims at creating for the elderly the place they can be and the role they can play in order to prevent them from bedridden condition and support them to continue living in a familiar place until the end. It is a major purpose of community-based integrated care. Of course, there is also the effect of reducing medical expenses and long-term care expenses to some extent. There is now a common understanding that utilizing community resources to their fullest and working together is critical. This kind of community building not only supports older people, but is also the foundation for a safety net that can address disaster prevention, poverty, and infectious diseases such as COVID-19. As a leading example of an aging society, Japan has undergone many ups and downs, but in the end, community-based care is the solution they have settled on to address this challenge. From the perspective of sustainability and ensuring no person is left behind, this perhaps seems like a natural solution, but it has taken Japan many decades to learn this lesson. By examining Japan's path, hopefully other aging nations can leapfrog over this country's growing pains and design policies that build on the most successful elements of Japan's system, namely UHC, an emphasis on healthy aging and prevention, and community-based care. Thank you for your attention. Please allow me to speak in Japanese in the discussion later, because it is much clearer for me to share the information with you through English interpretation. Thank you.
Thank you very much, Ms. Sakota, for your very powerful presentation. You have kindly shared Japan's historical context, in which, in a sense, they found a community after many trials and errors. You also showed how community-based integrated care is practiced on the ground and makes a difference in all the adults' lives in Japan. Thank you, Ms. Sakota. When we look at the other Asian countries, many countries promote a community-based approach, emphasizing coordination among different actors. So we have a common idea, but on the other hand, we need a nuanced approach when applying the concept in an actual situation, because every country and every community is different. So in the discussion session from now, we have 3 distinguished speakers from 3 different countries. They will share their experiences, which will be followed by a discussion. And we will explore how is their community-based approach put into practice in each country. What contexts are behind the similarities and differences among countries. And when can we learn from other countries' practices in realizing the concept of community-based integrated care? Well, let's get started. It's my pleasure to introduce the first speaker, Dr. Han. Dr. Han is the director of the Research Institute of Science for the Better Living of the Elderly and a visiting professor at the Daegu Catholic University, Korea, and the University Respati, Yogyakarta, Indonesia. I will now turn the session over to Dr. Han to begin. Dr. Han, please.
Thank you so much, and kindly introduce the chair. And then everyone, good morning and ohayo gozaimasu. This is Dong-hee Han from Korea, especially Busan, not in Seoul. I'm very appreciated this kind of webinar. It is very important. The aging population aging is very higher in every country. And especially the Asia Health Wellbeing Initiative and the Japan Center for the International Exchange and also the Economic Research Institute for ASEAN and the East Asia. Really, aging issue in Asia is very important because the half of populations or the people living in Asia, and also the aging phenomenon is a different sector. I think the 3 group very fast, and then the aging society, and then the very young population like Philippines. So we have each of the best practice in Asia. So this webinar, we share the idea is very important. I think population aging in Korea is absolutely the same in Japan. I think today the Ms. Sakota talk about the Golden Project, the 1989 to till now, the 33 years your experience talk about according to the community care. Our country also the very similarly project to follow because we have the aging is very fast, and also our older people live in the community. So as you know, our birth rate is very declined. It is very big problem in our government. And then comparing the low birth rate, the older population is very fast, and then increasing the population aging. And comparing Japan, our aging society started the 2000, and then our baby boomer is between the 1955 to the 1963. The first, the baby boomer include the older person, the 2020, and we will do the super aged society 2026. Your country, the 2005, I think. So my hometown, the Busan, is already started last year, the super aged society, the over 20s. So the 1963, our baby boomer will join the older person, the 2028. In Japan, the 2013. And also the 2035, we will have the older population, the 40. It is very fast. Everything is the population aging. And also the living alone population is very high. Not only the older person, also the young generation also living alone. With the population aging, the cost of medical treatment over 40 trillions won. It is medical insurance using the over 65 is 43.4%. This is very high. Every year this is the higher and the higher. And before long-term care, we have the universal health care and the long-term care system in Korea. So I will shortly how can the managers the care issues in Korea. So before long-term care, this is the empowerment system is started the home care services. So that is the before the long-term care insurance, but this kind of works after set up the government long-term care insurance. Our empowerment system is getting disappeared. This is one point of my emphasize our society, and also the focus on the national protection people is continually care according to the care management, and then whole services supported for them, but generally all the person do not have many kind of services now in Korea. And then our long-term care insurance that set up the 2008, and the enforcement long-term care insurance police. And then we had amended the long-term care insurance act to decide the grade. So we have now the 5 grade. So the different services delivery for all the people. And also our long-term care insurance focus in the dementia patient. So now from 2008 to 2020, and our older people benefit rate is almost 10%. So every, you can see every year it is increased the beneficiaries by the long-term care. As Mrs. Sakota said, not only the long-term care, we need the more services in the future, because the long-term care insurance in Korea is the first grade is getting decreased. So, but 3 grade, 4 grade, 5 grade is higher than before. It is very increased, and the total number of beneficiaries continually increased now. And also the dementia patient. And then now the 871,000 dementia patient in Korea. And 2024 will be the 1 million. And then because dementia rate increased with the age, population aging, the prevalence dementia will increase in the future. in Korea, we have the community care models for dementia patient. It is very unique. We have 265 dementia counseling center in community. So there is the doctor and the nurse and then occupation therapist and also the social work work together. And then the services for the dementia patients. It is only the dementia patients, not cover the whole our older people. So long-term care insurance is the daycare center, home care services, facility services, family support, something like this one is the services in Korea now.
Dr. Han, sorry for interruption. Yeah. Would you mind if you wrap up this in a minute?
Okay.
Thank you.
So aging strategy in Korea, the elderly welfare center, this is the focus in the community basis. So this is center is every community has 398, and then membership is the 2,050,000 elderly member is applied there, and then 1,400 workers in every community has the elderly welfare center. So activities, the welfare, and then care, they have doing that. And the health aging is a community medical center. In Korea, also every community has the 270. So dementia center and then health promotion, something like that. So now we have the community integrated care. We need, because the population aging is higher and higher. So our government decided the aging in place concepts. So this is a pilot project from 2019 to 2025, when our super aged society, it is spread the whole communities, this kind of a project. So pilot project was 2018, 2019. We have the 16th the project that Busan also belong to this kind of a project. So in Japan is only the older person, but in Korea we have an older person, disabled person, and the mental illness. So now the 13 is for older person, 3 is the other disabled and the mental health. So the direction community-based integrated care in Korea is the community basis, and the central government support in the formal informal corporations, multi-net, and the housing and the health and the care and the caregiver. So I introduced our Korean, especially Busan. We have the started 2012 to the 2012-4. So the 2020 we started only 2. And then now the whole Busan municipality pilot project, the community care and then community basis integrated care. So the main focus is aging in place. And the one-stop station in 15 minutes. In Japan is 10 minutes, but the Busan is 15 minutes. And then package services, care worker, home medical services, and then counseling. And also the AI smart home services. And then tried to make the Anshin care housing. And then this is our social family, not their family. And then the social family is connecting in a community. So we have the services like family systems. This kind of thing is our pilot project in Busan. So in the future, the community basis integrated, the model must be the super aged society and the lack of the care manpower and the independent life, non-institutionalizations. So the environment, age-friendly environment, and then the value of very important, because our Korean people only family is very important. So the family care is not come true. Most of our people go to the hospital. So not in the middle. So the community-based integrated care must be the middle, lots of developing the services, and then the universal related and the coverage services, advocacy of services is very important. So the key to community care is the sustainability and the cooperations. So focus must be the older person, not the prime, not the the hospital government. So community basis is very important for older person.
Sorry, Dr. Han, you have 30 seconds to finish.
Okay, so my conclusion is innovation and the challenge. And then many community try to make the good models, but most important thing is the working together, so formal, informal networking in community, and then focus on the person with the age-friendly city and the community. So even we are not come through everything, but every year tried to make the community basis, and it will come through the fruitful result. Okay, thank you so much.
Thank you very much, Dr. Han, for your very comprehensive presentation. So next speaker is from Vietnam. Ms. Nga is a senior manager at Help Age International in Vietnam, an NGO focusing on the well-being of older persons and adapting to aging populations. Her organization's initiative, the Intergenerational Self-Help Club, received the 2020's Health Aging Prize for Asian Innovation Happy Grand Prize, and is currently promoted by the government of Vietnam. Ms. Nga, please start your presentation.
Thank you, Mr. Nakamura. So today I will be sharing with you an aged care model in Vietnam called the Intergenerational Self-Help Club, or ISHC for short. And my presentation will consist of 3 parts. What is ISHC, its background and characteristics? What are the care services of the club, including who provide care and how we finance the model. So Vietnam is among the most rapid aging country in the world. Meanwhile, we are a lower middle income country with very limited resources. And according to a national survey, older people face more economic challenges, let alone the low coverage of pension. And in Vietnam, long-term care insurance is something non-existent. So what are the implications of this? It means that we have limited resources to respond to aging, to meet the care needs of people, and also older persons, they have certain difficulties in affording and accessing care services. So in terms of care needs, in Vietnam, the majority of older people, about 85%, are still healthy enough to take care of themselves. So self-care is the most needed and popular. And also in terms of care preferences as well, more older people prefer to aging in place rather than going to institutional care. So as a result, we will need a model that is community-based, cost-effective, approaches healthy aging to prevent health from deteriorating when we get older. And also it has to be standardized and scalable. And it resonates quite a lot with the policy brief of the experience of Japan, that we need to develop the community-based care system. So that is the reason why the Intergenerational Self-Help Club was born. And this model initially was formed by an NGO, by Help Age, together with local partners. And later on, because of its proven benefits, it was adopted by the government to become a national model, as indicated in 3 Prime Minister decisions in the slide. And also internationally, it also received international recognition like the Happy Prize, or endorsed by WHO, UN to be best practice in sustainable development, achieving sustainable development goals. So about the club, it's village-based, so it's very accessible to older people, and especially disadvantaged older people and older people with disability. It is divided into small groups with different interest groups, and also it is under the management of Vietnam Association of the Elderly. So in Vietnam, the Association of the Elderly is the official representative of older people's voice. So by integrating the club model into an existing system, it is more cost effective and it's easier to scale up the model nationwide. And the model is run by, it's directly managed by the club management board of 5 members voted by the members themselves. So it is very local, it promotes local ownership. And among the members, 70% are older people, 70% are women, and 70% are people with disability. So in a way, it addresses it is intergenerational. It not only targets the older people of today, but also targets older people of tomorrow. And it promotes the life cycle approach. And also it has the inclusiveness, targeting both disadvantaged and people who are more better off to create more sympathy. And it targets different people with different backgrounds. So it is inclusive. And one may ask, if a club only have 50 to 70 members, then the coverage is not very wide. But in fact, these are only the core members of the club, and the club targets the whole community, and it supports the community as a whole. I'll get to that in more details later. So ISHC is multifunctional. In fact, in the past, we used to establish club, but had 1 to 2 areas only. Like we have the income security club, we have healthy club, we have dancing club, for example. But now we move on to a multifunctional, holistic approach, and it works because it is more. It even helps the club to be self-sustained, and it will meet the better diverse demands of older people, because as an older person, you need income security, you need healthy aging, you need singing and dancing as well, not just one. So that's why the club is multifunctional. And because the club is multifunctional, it is able to provide a comprehensive care services to older people, including personal care, like personal hygiene, housework, and living support, support with cash, food, assets, social bonding, providing friends to ease with loneliness, and also providing escort services and provide healthcare as well. So these are the more details of the care services that you can read in the slides later. So does the club link with the health sector at all? The answer is yes. And not only health sector, the club also link with other sectors like social work, local social work, the Red Cross and local authority. In fact, in Vietnam, the ISHC is maybe the only one foundation that is able to link with other departments in Vietnam, and is also able to mobilize and promote local resources in providing care for older persons. So who will provide this care? So each club will have volunteers and also healthcare providers, and we have a standardized procedure to recruit the volunteers and train the volunteers as well. And these volunteers are all local villagers, and we based on the fact that older people are resources, not receivers only. And for every one sick and bedridden and intensive care need older person, there are 60 healthy older persons and community members who can provide care. So that is the basic behind who will provide the care. And as long as we have a strategy to promote local resources, the care providers will be there in the community and in every village. And we also have provide training to have care manager within each club. And this is the meeting of care managers with other volunteers and health care providers and the local authority as well. These are the management system, like they will have the bookkeeping system, they will have care plan, and all already standardized and well established within each club. So this is the care plan of the club. And the club also offer other services to improve the well-being of older persons, not just providing care alone, but for like promoting health, ensuring income security, and providing social care and social bonding, and many other activities that the club provides to be attractive to members, and also to meet the diverse demands of people, including lifelong learning, providing knowledge on how to take care of themselves, and many more. So how do we finance the club? The idea is that we will help the club generate its own resources. We will give the initial investment, and then we will provide training so that the club will generate at least 4 different income sources. And then the club will decide on their own how to use the resources that they are able to generate to invest in care activities, cultural activities, and other activities that they want. So in this way, it is totally managed by the local people. We help the community help themselves. Instead of bringing the care services to them, we establish foundation at the community level so that the care services will be provided by the community themselves. And of course, with the collaboration with other public sector and under the management of the local authority. There are still gaps. Currently, the IIC is only 3% nationwide. There's still a long way to go, so that we have one IIC in each village in Vietnam. And also, there are challenges in the big system of the management, because in Vietnam, older people issues is put under the Ministry of Labor, but healthcare is put under the Ministry of Health, and they do not really communicate. So there's a different challenges in integrating the care system. But overall, the initial investment of a club is 10,000 per club, and cover all costs need to establish a standardized club. And the idea that we want is to is not just in running an aged care model, but more like an older people promotion model, so that we can be able to use existing resources, and older people will be active agents of change, and they will be responsible, and they will be able to take care of themselves well, and with their families and communities. And that is the end of my presentation. Thank you for listening.
Thank you, Ms. Nga, for your excellent presentation on your fascinating initiative. The last speaker is from Thailand, Dr. Akaratang. Usually I call him Dr. Ok. Is the Deputy Executive Director of the ASEAN Center for Active Aging and Innovation, ACAI. He's also the Director of the Institute of Geriatric Medicine of the Ministry of Public Health of the Thai government. Dr. Ok, you have 7 minutes. Thank you, please. Dr. Ok, please unmute. Dr. Ok, please unmute.
Okay. Okay. Good morning, everyone. Please, Mr. Nakamura, share my slide, please. Okay. I have a share for you, for everyone here, about the community-based care in Thailand. Now in Thailand, the situation, by the last year, we have a 20% of aging people. We have a complete age society. But in the next 10 years, we have a 28% of the aging people that we goes to the super age society. Next slide, please. Okay, we have a burden of disease of the child elderly by the year of the 2014. In the male aging, we have a cerebrovascular disease, COPD, and ischemic heart disease. And in the female, we have cerebrovascular disease, diabetes, and dementia by the rate of the most common. Next slide, please. And now we have the geriatric syndrome screening by the year 2019. Number one, we have a problem of the oral health, 68%. And the second, we have a problem of the osteoarthritis knee, 63%. And the number 3, we have the problem of the vision, about 40%. Next slide, please. And we have a screening for the functional ability by the ADL in the year of the 2019. In the aging people 60 to 69, we have a screening for the ADL, the more than 12 scoring, 99%. But when we screening the aging people who have more than 80%, we have screening the ADL more than 20 decreased to 88%. That is significantly. Next slide, please. In the country Thailand, in the Thailand country, we have the elderly action plan from 2003. And now we have a national elderly plan number 2, the second from by the year 2002 and 2022. Next slide, please. We have a national agenda of the age society by the year 2019 to 2021. We have encounter the problem of the active aging about the healthy, security, and participation. And we cross an emphasis to the health system, the number 3. Next slide, please. We classify the all elderly people that who have a healthy behavior, and we have an individual plan after screening, and we have a community screening that we classify to normal and abnormal. If we detect the abnormal, we have a deep evaluation and care in health center and hospital, and we have an individual plan for the long-term care and dependent elderly care. Next slide, please. Now we have many applications to screening the aging people. Example that we have aging data, aging health data, and we have application 5G for the general people that they can have a self-health check by screening by themselves. And we have education and game for them, for the family and the individual people general. Next slide, please. And about when the people is diagnosed, we have a team of the acute care, especially for myocardial infarction in the pre-hospital and stroke. Next slide, please. And now we have emphasis that we encounter the in-hospitality mortality for ischemic heart and ST-elevated myocardial infarction decrease from the 10-year era. Next slide, please. And now the intermediate care. We have a plan from the past and now to the 2019 and this year. We have a situation, problem, need, and potential solution for the intermediate care in the 4 health region of Thailand. Next slide, please. And the intermediate care for 2020 plan, we have a knowledge or the KM, and we have a theoretic issue for the intermediate care, and we create a model development for the 6 building blocks for intermediate care to the hospital intermediate care ward, intermediate care bed, and we have a community rehabilitation center. Next slide, please. Now we have a lesson learned from Thailand National Community-Based Long-Term Care Program for the older people. Next slide, please. We have a National Health Security Office for the reimbursement. We have a caregiver all of the country. And the next step, for the community-based program in Thailand, we have a developed service for the older people. Next slide, please. We have a district hospital and health center. We have the National Health Security Office have a training for 10 million, for 100 million baht for the district hospital and healthcare center for training the people who have a caregiver, and they get 500 million baht for the local administration organization to local health fund and the center for the older patient for the long-term care and managing the caregiver all of the country. Next slide, please. In 2018, we use 35 US billion for the targeted, the long-term care and caregiver for this budget. We get 200 person for this long-term caregiver. Next slide, please. And we have a category for the group eligible for benefit package. We classify for the group 1 that partially move, and the group 2 have a cognitive disorder, the group T for not able to move, and the group 4 for serious illness or palliative care condition. That is different from the budget that we use for full group. Next slide, please. We get a community-based care for the local and network for long-term care for the older people. Next slide, please. In the problem of we have a limitation of household.
Dr. Oak, would you mind if you wrap up your presentation in 2 minutes?
Oh, thank you. Okay, we have a limitation of household for long-term care because we have a decreasing for household size. Next slide, please. And we get the model of the long-term care by use very many ways. Next slide, please. Okay, next slide, please. Okay, we have the level of practice for the one first for household, family member, the community or village health. Next slide, please. And we have a virtual community for the family member, neighborhood, religion person, and health personnel. Next slide, please. Also, we have a local for the sub-district administration, organization, and the network, that the doctor, local network, and local hospital network. Next slide, please. Next slide, please. Now we have a program for the community-based about Japan and Thailand for the long-term care. Next slide, please. We have a Ministry of Public Health Thailand same-day aging care that we classify to the acute care, intermediate care, palliative care, and the long-term care. Next slide, please. And now, in the past from to now, we have a JICA C-top, L-top, and S-top model that launched in Thailand. Next slide, please. We have a training program. Next slide, please. And we have a use of 3C, care manager, caregiver, and care plan. Next slide, please. We have a specialized box for the long-term care dementia. Next slide, please. Okay, we have a health promotion, screening, comprehensive assessment, and classify and treatment. Next slide, please. We have elderly home caregiving volunteer. Next slide, please. We use this strategy to the elderly school and community-based elderly development center. Next slide, please. We have a dementia awareness and health literacy all over the country. Next slide, please. And we have a history of dementia care system development in the 5 areas in Thailand. Next slide, please. Until now, 2019. Next slide, please. This protocol we have implemented for 3 years. Next slide, please. And we have many ways to screening and goes to the strategy and action plan. Next slide, please. Okay, the last topic for me is the Asian Center for the Active Aging Innovation. We have a mission like this. One, we have a knowledge center for the active aging and innovation. And the second, we support the evidence of informed policy. Third, we have a implement capacity development program. Fourth, we have a research and development innovation for supporting aging. And fifth, we have support the monitoring of progress of active aging in Asia. Next slide, please. Next slide, please. Now we have next slide, please. Now we have a temporary AKI office that Mr. Nakamura will visit me on this Thursday at the second floor of Department of Medical Service of Ministry of Public Health Thailand. And now we have the under construction for the new permanent AKI office by the year, and the start from 2020 and will result by this year. The last slide. We have a now global action plan for the public health response for the dementia by the year 2017 to 2025 from the World Health Organization and the Thailand. And from the relation between Japan and Thailand, we have a national strategy for dementia. And we have a 6-step care from 2021 to 2025. Next slide, please. What is the next step? We focus on the people, family, and community for strengthening aging and elderly health literacy and the intergeneration, multi-sectorial, and we emphasize to the full-time paid caregiver and flexible model of geriatric clinic and improve geriatric intermediate care and specialized long-term care system. Thank you very much.
Thank you very much, Dr. Oak, for your very informative presentation. Now, let's start the discussion. Ms. Sakota will kindly join. So we have about 20 minutes, and we got many questions. So I cannot take all the questions due to the time limitation. And so I will highlight issues that concern many participants. Okay, so my first question is about the process of building their community-based integrated care and continue their initiatives. So how to make community-based integrated care happen and continue, and what is the first step, and how can we encourage people, whether professionals or non-professionals, to work together and continue to do so? First, I would like to ask this question to Ms. Sakota. Could you share Japan's experience about this point?
Thank you very much for that question. In Japan, this community-based integrated care depends on each community. It varies quite a bit. So urban community, remote community, maybe suburban community, and then also multi-unit community, those are very different. I heard the presentation from Vietnam. I think health age impacts this community-based integrated care very much. So it is important to have a key person in each community. And then this key person, for example, in Kunitachi, in my example, so that was a group of physicians in Kunitachi, but it doesn't have to be everywhere. For example, NPO can be the core, or maybe home care people can be the core of the community. So whoever it is to be motivated, those people can start the system of community-based integrated care. And then these people do not have to be HCP at all. So whoever motivated can start or galvanize the process. And on top of that, of course, the support from the local community or any levels of government would be important. And then also, we need to think about the historical background of each community. So there are some communities who are more successful with community-based integration care because those people in that community tend to be close with each other when they are young as well. So it is difficult to have people be connected with each other just because they're older. And then so when they are younger, it is important to have really close-knitted community, and then also they can develop their specialized skills, for example, in medicine and also home care. And then so I think that that having a good key person and also having a good basis of community is those are really good starting points. Sakoto-san, thank you very much.
It takes a long time, and it is very the context sensitive. So it's a kind of evolving process. That's what I understand. Thank you very much for your the answer. So, Dr. Han, you talked about innovation. So, I'm wondering what are the key features from innovation in your initiative?
In Korea, already there are many community-based the facility, but we never talk about community-based integrated care. So fortunately, our government recognized the fasting the super-aged society, and also our older people do not want to go to the facility, do not want to go to hospital. Most older people want to stay on their house, but the gap is very different. So finally we started a pilot project about this one. So each of community, each of municipalities, different community basis models. Yeah. So the in Busan cases, we are the smart aging small village, and then the controlling, the monitoring, what happened with the older people, and also the I said people making the social family. Because the living alone and then very vulnerable situations, they don't have any family or not so good the network. So our society, our community make the family, and then asking the very emotional support, and also we deliver many services. So I think not enough, but we must challenge as a name of the community basis, the integrated model. And already we should talk about in the village, and then delivery such as the technology, and also the very emotional approach. This kind of I think the innovative things, because the most people think about care is a hospital. No, in the future, even in small village, we do the many kind of services, and then our older people select services. That's the framework. Yeah, so that is the important, I think.
Thank you very much for sharing the Korea's their concept of their integrated care in the community. And I got some questions about access to their services, necessary services, especially for the marginalized people, like low income older adults or very frail elderly people or older adults. So I think your answer is a kind of the hint or there's some key to overcome their challenges. So I would like to ask the question about the access to the services in Thailand. For Dr. Oak, in Thailand, I understand there are some people living in rural areas who has a very difficulty in accessing the necessary health services or other services. So in Thailand initiative, how do you ensure the necessary services to these for these vulnerable or older adults?
Okay, thank you, Mr. Nakamura. So in Thailand, so now we have many problems that we confess that we have more team and more group to do this platform. First, we have a primary healthcare team for the all age group, Now, so in Thailand, we have the community center, maybe more than 10,000 center to action plan for this. And now we have a care team more than 1,100 multidisciplinary care team to do long-term care and the track along this system. And we have more the health volunteer, more than 1 million people, or in Thailand, we have, we call in Thai language that the Osamo is distribute and spread that all of the country. And now we have long-term care teams for dependent old age group. We have classified for the care manager more than 12,000 people to exercise this action plan. And for moreover, we have more 27 semi-paid caregiver that they can get a salary for 500 baht per month for them to help the caregiver all of the Thailand. So also that Thailand have we have a seamless aging care all of the country. We start from the acute care, and we have a treatment, and after that intermediate care, and the go to the long-term care system. And from the experience that we have helping from Japan, from JICA, C-top, L-top, and S-top, from the project of the seamless health and social service provision for elderly person, helped Thailand very much for contribute and the construct of the system for the elderly care in Thailand. So now by conclusion, the long-term care system in Thailand, we have a first caregiver, second care manager, third care, and we have a care plan. And especially in this year, we are focusing on the dementia care plan. And fourth, we have a long-term care funding from the National Health Security, we call that NHSO. And the last one, the fifth topic, we have an intermediate care system in hospital and in community also. Thank you.
Thank you very much, Dr. Ok, for sharing the Thai experiences. And I understand initiatives in Thailand for their long-term care is built upon their strong foundation, which has been built over the last many decades, like solid, robust public health infrastructure, and also their 1 million health volunteers nationwide. So I think their experiences, of course, they're highly context sensitive. Thank you very much, Dr. Ok. I got another question, which is about the financial sustainability of their community-based integrated care model. For example, in Vietnam, you are promoting the ISHC, Intergenerational Health Self-Help Club. So could you please, Ms. Nga, could you please share your way or your initiatives to sustain your initiative financially?
Sure. Allow me to go back to this slide. I think it's a bit easier for you to look at the slide. So as you can see that the blue parts is income resources of the club. The first resource is loan interest. So each club will have a revolving loan fund. So as I said earlier, the ISHC is multifunctional. So not just healthcare, but also income security and other activities. And under the income security activity area, each club has a revolving loan fund that they lend out and they collect the interest. So every month, the club has a stable income coming from the loan interest. And in this way, older people can access to microcredit and at the same time sustain their club. And the second resource is from the membership fee. This fee is very, very small. Everybody can afford it. It is more like a responsibility kind of fee rather than a significant income sources, but still it is another income. And then the third one is local fundraising. And this one can bring a lot of money to the club. The thing is, we build capacity for the club members, how to raise fund on their own. They can organize events, they can use they can organize charity, they can organize local fundraising events. They invite donors to come to visit their club. They can call upon the children working far away and many other people. So as long as the club is good, people will know about the club and they will donate to the club, because you will need to focus on having a good club first. And then when you have a good club and everybody likes it, they will contribute to the club. We call it strong buy-in. The internal resources is limited if we know how to promote the club properly. So we teach the club members how to raise funds on their own using different activities to attract donors. And then the fourth income sources is the club, the livelihood model. So for example, this club in the rural area, they see a piece of land that is not used, and they ask the local authority to give them that piece of land to grow bananas. And they together, they take care of the bananas and they sell the bananas and they have the money. So it is very flexible. So in urban area, mountainous or coastal areas, you have their own livelihood model, and you can do whichever model you want as long as it brings income and the club do together. So the club will have at least 4 income sources of cash. This is cash. And other than cash, they also have other sources like technical. For example, they will collaborate with the health sector to organize health checkup for free, because it is the responsibility of the health staff to organize the health checkup anyway. So instead of the health staff organize the event on their own, they can collaborate with the club. And the club will provide logistics, organization, they will invite doctors, they will send invitations to members, and the doctors just to come and provide the checkup. So there are many activities they do free of charge, because they will be able to link with other existing service in the community. They can link with the social worker, they can link with the local authority to invite trainers to the club, because the club has become a national model. So it is easy for them to call for resources. And the club is endorsed by the local authority. So when they approach business, when they approach donors, it's easier for them to call for fund. And the club is right there in the village. So everybody sees the impact of the club. So they know that if they donate to the club, the money will go to the club fund and the money will turn into these effective activities. So that's why they do not only attract new donors, but they also attract existing donors. They will continue to donate to the club as long as the club is there in the village. And many children of the club members, they working far away in industrial areas. And when they see their parents taken care of by the club, they are very happy to donate to the club. And so that is the different income resources for the club. Of course, the club will not start from zero. It will need initial investment. As I said earlier, each club has about, if we want to have a very good standardized club, we need to invest about 10,000 USD. Of course, of which 5,000 is for the revolving loan fund. We call it the start grant. And then 5,000 is for infrastructure and capacity building. Where does the $10,000 come from? It comes from different resources. In Vietnam, the money comes from, firstly, the Older People Care and Promotion Fund. It is an existing fund in Vietnam, and then it can also come from the national and provincial budget, because the club helps address aging population, and it helps providing care for older people. So as long as the club are effective, the local authority are willing to invest the provincial and national budget into the club. We have provinces that provide the club with 100 million VND, that is about 5,000 USD at the beginning. And then we also have Fund for the Poor. In Vietnam, it's also a social fund, Fatherland Fund, Social Security Fund. We have different kind of funds in Vietnam that we can mobilize to invest in the club. So each province will have their own income fund, their own funds, and they can mobilize the funds to the club. As long as the club is good, it's effective, and we are able to prove that to the local authority, they are willing to invest. And it just takes 0.03% of Vietnam's GDP to replicate 100,000 clubs in the country. So it's very affordable, and we do not focus on one resources only, but we focus on many other income sources. And the thing is, we have to have a good club first. If the club is good, the money will come. So that is the principle behind the financial sustainability. Thank you.
Thank you very much for sharing your very innovative way to develop their various sources of funds. Thank you very much. So time's now running out. Okay, so my last question is about their consideration to younger generation. I would like to ask Ms. Sakota about this point. Especially in Japan, the younger generation has a lot of financial burden, and they have to work hard to support their older persons, older adults. So how do you ensure, how would you ensure the younger generation's dignified living in Japan?
Thank you very much for that question. It's a little bit difficult for me to answer. So in Japan, community-based integrated care that was needed from the elderly population. So Dr. Han, you talked about this as well. And so there are some populations that who have very limited income sources, and also single mothers, single parents, and also people with disabilities. And so those people also targeted to be included in community-based integrated care in the future as well. So in Japan, there's a growing number of restaurants for kids. So for example, kids who don't have good food security at their own households. So that means that we can open up community-based restaurants that serve good nutritious meals to kids. So that kind of activity has started. And so that's called Restaurants for Kids in Japan. So my presentation focused on activities and also initiatives for the elderly population in Japan, but at the same time, in Japan, there are other initiatives aimed for younger people or even kids, and then also multi-generational activities as well. So it is important to have a wider perspective that we are not only doing things for the elderly population, but at the same time, we're trying to include and also serve all the populations and also generations as well.
To promote their community as a kind of common foundation for their decent living for their everybody. Thank you very much. So now I have to close the discussion because of the time limitation. So I'm very grateful to each of the speakers and Ms. Sakota for your inspiring their comments and their answers. And I look forward to having another opportunity to share each country's progress, to continue this discussion. So, and also I would like to thank the audience for their active participation and many good questions. Thank you very much. So this is the end of the discussion. Oh, okay, sorry. So let me introduce Dr. Kato for their closing remarks. Thank you.
Okay, thank you very much, Dr. Nakamura. Hello, everyone. I'm Takuma Kato, Director for Healthcare and Long-Term Care Policy in Economic Research Institute for ASEAN and East Asia area. So thank you very much all for joining us today. ERIA is a co-organizer of this webinar, but I personally really enjoyed the discussion beyond the position today. So 1 hour and a half was very short for me, and I hope for you as well. And thank you very much, Mr. Nakamura, for your magnificent job as the moderator. And to all the distinguished panel members, I'd like to express my great appreciation for your valuable and insightful discussion today. So this is the fourth event in our webinar series organized under AWIN. This time we try to discuss community-based integrated care. Some people may more familiar with community-based care. We discuss these topics a bit from a bit different aspect from past three events. We invited Ms. Takota to give us a journalistic perspective on the current long-term care situation in Japan. I thought she showed more user-side examples and experience rather than just overviewing the system. From my experience, policymakers are more likely to listen to the opinions from researchers and service providers to understand the comprehensive visions. But I think opinions from the journalistic or general public are very also important to understand if the system is simple and attractive enough for service users. So thank you very much, Ms. Sakota, to joining us today. And we also learned that there are many differences between countries and regions regarding the situation of aging and resources that communities have. So that information is very helpful to evaluate supply and demand of community-based care system when we consider new services, particularly. In addition, a situation of one country or region could be a future vision of another country or region. So I would also like just a bit to talk about Happy Hours, Health Aging Prize for Asian Innovation, because more detail will be announced after my speech. ERIA is also a co-organizer of this award. Happy Award aims not only to encourage people to come up with a new and innovative idea, but also to disseminate best practices widely so that those in other areas can copy or modify them to adopt into their community. So I'd appreciate if you'd keep your eyes on Happy Award as well as our webinar series. So that is my brief comment of today's discussion. I hope that today's webinar is useful and applicable to your work. To our guests and panelists and to our audience, thank you again on behalf of the co-organizers, JCIE and ERIA. As I mentioned, this is the first event in our webinar series organized under the auspices of the Asia Health and Wellbeing Initiative, or AWIN, an initiative launched by the Japanese government. To view past webinar or learn more, please visit our website at awin.org. I hope to see you again soon at our next webinar. Thank you very much. So maybe I have to hand over to Momoko-san.
Hi, thank you, Takuma-san. And so as he mentioned, the applications for the Healthy Aging Prize for Asian Innovation is currently open. So please let me spend the final minute speaking about it. So can I have the closing slide? Thank you. And so in this award, we aim to recognize and amplify innovations that address the challenges facing the aging societies. So next slide, please. Yep. And the innovations that we accept could be a policy, program, service, or product that falls into one of the three categories shown here: technology or innovation, community-based initiatives, and supporting self-reliance. And earlier we had Ms. Na from HelpAge International Vietnam presenting the IHC model, which actually was the grand prize winner in the community-based initiative category for the first Happy that we organized. Through this award program, we hope to identify various good practices that are taking place in the field. So if you are interested in this initiative, please do spread the word and encourage the frontline players in this field to apply their outstanding work. And may I have the next slide? And last but not the least, we will be holding another webinar in 2 weeks, and the dates are now shown on the screen. The next topic we'll dive into is on innovation for healthy aging, where ERIA JCIE will be joined with OIST, the Okinawa Institute for Science and Technology Foundation. We'll bring together a panel of representatives from both the academic and business sectors to discuss the importance of technology transfer. So further details will be available again on the ARWIN website. So please do check it out together with the information for HAPI. So that's the real end of today's webinar. So once again, thank you everyone for joining us, and we hope to see you again in the next webinar. Thank you and bye. Have a good day.